Sorry, I really didn't pause for the thank you of our panelists, but I should have. So I want to thank you all. All right, thank you. So with that, I'll let you get settled, Sherry, and then you can introduce your panelists.
Thank you. I don't want to be the only one that's standing between you and lunch. Okay. So good morning, maybe good afternoon. I'm not quite sure. Sherry Little, as Madam Chair pointed out, I am the Chief of the Health Policy and Research Division. And joining me today is Bob Causeway from our San Diego Office of Milliman, and Gary McCollum, who we can't seem to leave alone. He's our retired health actuary. So we're going to continue and build upon our conversation that we had in our January offsite about regions. And the reason we do this is for the sustainability of our healthcare program at CalPERS. It's really our intention to remain competitive in the marketplace and to make sure that what we do in terms of regional breakdowns provide the greatest benefit for the greatest number of people. This is an informational item, so we hope we provide some value in that, and that we can give you a common understanding of the history, the background, the methodology, and the challenges of geographic regions. So as a refresher, just from our last offsite, I'm going to go over a couple of points. Milliman's going to talk to you a little bit about how the regions were originally established, and also give you a market scan to give you some context around that. And Gary's going to talk about regional variations, both the pros and cons, and potential scenarios moving forward. I'm also going to talk to you a little bit about what we're doing in terms of stakeholder outreach and our next steps. So, a little reminder from last time. When we're talking about regional rates, we're talking about two different things. We're talking about regions and regional factors, both of them going to rate buildup and premium buildup, and they are interrelated. But for today's conversations, we're going to focus solely on that region's piece of the pie, and we'll go back to the regional factors at a later date. A region, for a reminder, is really about counties, it's about zip codes, and you'll see in your handout, sorry, you're just getting it now, handout number 1, you'll see the regions as they're currently built out. Regional factors are a measurement that really represent what you would take if you took the same family with the same healthcare conditions and moved them from one geographic area to another, what that would look like and what the cost of healthcare would be, how that would vary. So today, we're just going to focus on the regions portion. Historically, CalPERS had one region. In 2003, we lost about 17,000 agency, predominantly in the Southern California area, and that was really because the cost of healthcare was above market to stay with CalPERS. So the board tried to stabilize that. So in 2005, we wanted to stabilize that risk pool and approved some regional pricing for our agency members, to better align our premiums with our public agency members. Since that time, we moved yellow into the Sacramento region to create the 5th region. And today, as you recently experienced in our 2019 rate development process, you've seen some volatility in regions that have forced some health plans to move out of specific areas. It's been 13 years since we revisited this, so we thought it was a good time to kind of look at the objectives around regions. It was our intention to really create that stable risk pool and make sure that we're retaining all of our public agencies and schools. We also wanted to create regions that made economic sense to everybody and really create a certainty around that. And we wanted to create regions that retained and attracted employers, and we've had some success in that. So between 2005 and 2017, we retained 60%. Our Southern California population increased by 60%, and overall, we've grown 26%. But we've also faced some challenges. We want to minimize that volatility and that fluctuation and create a stable environment. We know there are a lot of these factors are out of our control, but to the degree we can, we want to try to minimize that. And despite that challenge, I don't know where Rob is, but we've maintained a 99% retention rate, so good job to the marketing team on the public agency side of things. In January, we talked to you a little bit about the difference between regions and regional factors. We talked about how we determine PPO regional factors and how we receive HMOs independently on the regional factor side. We also told you we would do a market analysis and talk to you about our plans moving forward and our stakeholder outreach. So at this time, I'm going to introduce Bob Causeway from Milliman. Bob has had extensive experience with the CalPERS team and will continue to work with us as we move forward on this project. He was instrumental in first establishing regions, and he specializes in a variety of healthcare areas. He is a fellow at the Society of Actuaries. He is a member of the American Academy of Actuaries, and he holds a BS and a master's degree from a little-known school called MIT. So with that, I'm going to turn it over to you, Bob.
Thanks very much. It's nice to be with you today. Milliman's role in this effort is to evaluate whether the current regions are meeting CalPERS objectives. And briefly, we understand that the objectives for the regions are to be able to attract and retain membership from the public agencies. As was said, prior to 2005, CalPERS had one flat statewide rate for each health plan. Public agencies could purchase, and still can purchase, health care either through CalPERS or purchase health insurance on the market, or there are other pools in California that are available. Even though CalPERS can offer more cost efficiencies than buying direct, the variation in market premiums by geographic area is a key factor for public agency decision-making. When a public agency in a lower cost area, such as Los Angeles, compares their direct purchase options in the market to CalPERS, prior to 2004, they would often have to pay more to be in CalPERS than if they were to purchase insurance on the open market. Similarly, a public agency in a high-cost area in 2004 would tend to find CalPERS rates were very competitive compared to local rates. So the goal of the 2004 Milliman analysis was to define regions that had similar healthcare costs. This would allow the carriers in CalPERS to set premium rates for each region that are more reflective of the market. So the 2004 analysis was fairly actuarial or statistical in nature. We wanted to look at CalPERS' own data, and we looked at the relative cost factors for each county and each health plan. And we focused the analysis on basic members, active and retirees under age 65. So we think of the relative cost factors as the total healthcare costs in a region divided by the total covered lives. So it's basically what is healthcare cost per person. And we wanted to identify county to county cost differences that were due to the healthcare delivery systems in those counties, not necessarily differences due to the characteristics of the employees and dependents. So to do that, we looked first at the cost, and then we looked at the members, and we looked at how at the health status and the family composition of CalPERS members from county to county, and effectively adjusted the observed cost to remove the effect of difference in health status and family composition. So we estimated what each county's cost would have been if its CalPERS membership had the same health status characteristics as the whole state, the membership of the entire state. And after this adjustment, we believe we can focus on the remaining cost differences, which are really based on the intrinsic healthcare market features in each county. So using these adjusted estimated healthcare costs, we then work closely with CalPERS staff to group counties into rating regions based on the geographic location and looking for counties that had relative cost similarities. And based on the analysis, CalPERS elected to create 4 rating regions. First, California was split into the north versus south, and then each was further split. The north was split into a combined Bay Area and Sacramento region, and then there was an all-other Northern California region, and the south was split into the Los Angeles area and an all-other Southern California. Since then, as has been said, the only significant changes were in 2009, the combined Bay Area and Sacramento region was split into 2, and in 2014, Yolo County was moved from Bay Area to Sacramento. The assignment of the counties back in 2004 and since has not been a purely mathematical exercise. Since all counties in one region will have the same CalPERS premium, the goal is really to be market competitive. We want to group counties that have generally similar healthcare costs. On the other hand, too many regions could be administratively complex, and smaller regions would be subject to more fluctuations in premiums from year to year, leading to less consistency in rates for these local agencies. So we're in the process of updating that 2004 CalPERS analysis, but we're also working with CalPERS to conduct a market analysis. And by that we mean, what can we learn from other payers about how others have dealt with the geographic cost differences. So we're really looking at 4 things, which I'll describe briefly. First, how do other state health plans address regional cost variation when local agencies are eligible to participate in the state program? Second, how are regions defined for other healthcare programs in California? Third, what are the alternatives to CalPERS that are available to local agencies, and how do those alternatives deal with regional variation? And finally, are there statewide plans available to private employers that have to deal with similar regional cost differences? First, with respect to other state employee plans, we've reviewed all 50 states and confirmed that there is no other state that defines rating regions like CalPERS. We also specifically did more research on some of the larger states and western states. And many of these and other states have some regional rates because they contract with regional HMOs that aren't available statewide. And that effectively results in regional HMO rates. In these states, though, all plans that are available throughout the entire state have the same premium in the entire state. So that they don't create rate regions, but if there is an HMO that's just available in one region, then effectively that's similar to having a regional rate for that plan. So again, CalPERS' approach to rating regions is unique, but in many ways we think California is unique, that other states have variation throughout the state in healthcare costs, but the stark difference between Northern and Southern California is really quite striking and not something we see in other states. And also, another difference is CalPERS HMOs are generally offered by carriers that are licensed throughout the state, as opposed to other states where there may be 4 or 5 different HMOs, each in only one region. Next, we wanted to look at, within California, what other programs are there that acknowledge and deal with variation in costs by region. And there are 2 that we identified. One is Covered California, which is the ACA marketplace. Covered California uses 19 rating regions, which was permitted under the ACA. There was a range that was permitted, and the California State Legislature selected 19 regions. And the small employer market in this state also uses the same 19 regions. And I'll talk more about Cover California. The other program that is somewhat relevant is when CMS pays physicians for services under the Medicare program, they use a rate structure that has that varies by area. And they currently, since 2017, divide the state into 27 regions. But the Cover California market really is most comparable to CalPERS. The Affordable Care Act put a lot of restrictions on insurance carriers, such as no rating for health status and no, basically no underwriting. But the law did allow regional pricing. And the state legislature, we understand, adopted the 19 regions to encourage carriers in this state to be willing to participate in Covered California and individual reform, and also to give more options to employees or to individuals to purchase in all parts of the state. The 19 regions for Covered California are like CalPERS, defined by counties, with one exception, and that is Covered California believed that Los Angeles County should be divided into 2 regions. So the map on this slide, each of the colors represents the 19 regions that are currently in place for California's individual and small group insurance markets. Let's go on to the next. So the third sort of market assessment we're looking at is really looking at our potential customers, namely the local agencies. So currently their options are to purchase insurance from CalPERS or directly from an insurance carrier or a third-party administrator, or there are a variety of pools that have been set up in the state that market their services to these local governments. For the agencies that go direct to an insurance company, they typically negotiate a rate based on their own experience. So it's not so much do they have regional pricing, but they tend to have costs that are calculated or estimated based only on their experience. When a public agency joins one of the existing pools, the situation varies. There are about 20 to 30 pools or trusts in California that are available to local agencies. The largest, I believe, are the Self-Insured Schools of California and California Valued Trust, both of which cover school employees. The way that these pools set rates for a given employer varies. In some cases, all employers have the same premium rate and no variation. That tends to be the case in smaller pools that are regional in nature. The other extreme are pools that cover employers all over the state, and in that case, we do see examples that have set up regions and regional rates. In fact, there are at least 2 that have adopted the same regions that CalPERS has. There are also hybrid examples where a smaller employer that joins a pool gets a fixed rate, the same rate as all other small employers, while larger employers are underwritten when they first join and have a rate that's dependent on their past historical experience. Another market analysis that we're working on is to look at what is CalPERS penetration in the local agency market. So on handout number 2 that you've received, this shows the penetration of CalPERS among public agencies. And for this work, we've defined public agencies to be counties, cities, and school districts. And we've left off the special districts and other sort of miscellaneous employers. The first map on the left, the color indicates the percentage of public agencies in a given county that are enrolled in CalPERS. And the second map shows the percentage of employees that are in those employers that are enrolled in CalPERS. So it's more weighted toward larger entities get more weight in that analysis. So just to give a little perspective, there are about 1,600 cities, counties, and school districts in California. And of the 1,600, 29% are in CalPERS. So looking at the map on the left, if you kind of think of the average shading for the whole state is about 29% CalPERS penetration. So counties that are shaded darker than average means that CalPERS covers more than 29% of the local agencies in that county, and counties shaded lighter than average indicate that CalPERS covers less than 29%. While CalPERS covers 29% of cities, counties, and school districts, we estimate that looking at the employees in those employers, CalPERS covers 21% of the local agency employees. This suggests that local agencies that enroll in CalPERS tend to have fewer employees on average than those that do not enroll in CalPERS. So the analysis that we're now working on with staff is to look at the shading levels and looking at distinct differences between one county and the next, and it indicates that CalPERS is relatively more or less attractive to local agencies in those counties, and we're trying to identify to what extent that's due to the regional definitions or how much of it is due to other purchasing factors that local agencies are facing. Handout 3 is a different view of it. This looks at the average premium rates for the other program I mentioned, Covered California. So Covered California has 19 regions, and we've selected a sample plan, the PPO Silver plan offered by Covered California. That's on the left. So the colors indicate the premium for that plan in a given county, and to make it more comparable, we've converted them to be the premium relative to the Sacramento County premium. So it's been rebased to be all percentages of the Sacramento County premium. And doing that, then we can compare that to the right graph, which is CalPERS. CalPERS, you can see 5 regions, and we've shown the one of the PERS PPO plan premiums, again, rebased to be compared to Sacramento. So because there are more regions in Covered California, we tend to see a wider range of premiums because the more you group counties into fewer regions, it tends to average out county-to-county variation. Finally, CalPERS staff and we wanted to look at private employers to get a sense of how private employers in California deal with regional variation of costs. And if we consider large employers that are purchasing health care for their own employees, we don't believe that the situation is comparable to CalPERS, because CalPERS challenge is really how to offer competitive rates to local agencies, whereas a large employer is basically trying to find the most cost-effective way of covering their own employees around the state. However, there is a somewhat similar option that private employers have in the state that is somewhat similar to CalPERS, and that is that some private employers, often those in specific industries, have access to multiple employer pooling options, such as MIWAs, multiple employer welfare arrangements. So employers in this type of pooling can often be spread all over the state. So how do those pools deal with pricing differences by region? In our experience, in most cases, they don't have specific rating regions, but instead each individual employer, when they join a pool, has to go through an underwriting process, and they receive a premium that is reflective of their own expected experience. So it's not so much pooled, but each employer tends to have a premium rate that is based on their own experience. In summary, we started with a wide view for the market assessment, but it concluded that the private employer market, as an example, was not really a fruitful source of information relative to the challenge that CalPERS has relative to regional rating. Our work to date suggests that an updated analysis of CalPERS claims experience by county will be an important part of the assessment, as will further analysis of the market penetration of CalPERS among local agencies in the existing regions. So now I'd like to turn it over to CalPERS recently retired health actuary Gary McCollum to discuss the next steps in the analysis.
Thank you, Bob. Good morning, everyone. I'm very pleased to be back. I think it's appropriate that we're following a discussion on opioids because I tried quitting CalPERS completely and I couldn't do it. So I'm going to go out slowly over the next 5 months. I'm very excited about doing this project. I really am. It should be very good. So I'm going to cover some of the barriers that contracting agencies face when they contract for health. I'll discuss real quickly the pros and cons of regional variations, and then I'll talk just a little bit about how regional scenarios are developed. So besides the issues and the challenges that we here at CalPERS face, I want to remind you that there are barriers that contracting agencies must also address in addition to just cost and regional plan options. There's 3 of them primarily. These include, number 1, not all contracting agencies can agree to provide health coverage for retirees, which, as you know, is a requirement to be in the CalPERS health program. Some of you might remember a former board member who told us that his county was not in the CalPERS health program because they couldn't afford to provide the retiree health coverage. So number 2, some contracting agencies may be looking for lower value and lower cost plans so that they compare an HSA or an HRA to the plan design. We had a discussion earlier about that. And then finally, there may be brokers and health plans out there that are offering similar products for lower cost for any number of reasons. And in some cases, contracting agencies have seen some what we call sweetheart deals that save money over the CalPERS plan options for a short term only. Some people might call that a bait and switch. So, should CalPERS have fewer regions or more regions? There's pros and cons associated with both. Currently, as you know, we have 5 regions. Covered California, you just saw, has 19 regions, and CMS also, you just saw, has 27 regions. So what's the magic number? Is there a magic number? So with fewer regions, there will be more covered lives in each region. That's good. That tends to make costs less volatile year to year. It also makes administration less burdensome and less costly for CalPERS. However, it's likely that there will be a larger differential in average costs within the subregions of each region. And that means you're going to have entities that will argue that their cost does not really reflect the cost that they're being charged in the region that they're in. So let's go to more regions. With more regions, we get average costs that are more reflective of the region, obviously. However, there's less covered lives the more regions you have. So that makes the chance of cost volatility year by year much more likely. And in addition, More regions means more expense, more burden to CalPERS. And also, we have to remember that the Controller's Office has a stake in this also. So it's additional cost to the Controller's Office. So, over the next few months, our job will be to create regional scenarios for analysis to bring back for your consideration. We'll look at the cost of healthcare in different ways. For example, should we group regions by zip code? Should we continue to group them by county? Or is there another way that we might group them? As you saw, Medicare groups by what they call metropolitan statistical areas. So should we consider splitting counties in some way? A good example of that would be Los Angeles County. Most of its population is in the southern part of the county, and up north it's fairly sparse. Also, San Bernardino County, which is actually the largest county in the nation, has most of its population on the west edge there with San Bernardino, Fontana, Rialto. And you go out east in that county and there's very little out there. So another question, should our regions that we create be contiguous? Or could we have a region that's made up of, say, some northern counties and some central California counties? If you remember the map of covered California, they do have their northern region, which is all the way up north part of California, and then there's kind of Sacramento in between, and then there's a few counties along the east side of California that are included in that other northern. So they're not contiguous. So after that, we'll run models for the different scenarios we create. We'll look at the regional costs that are generated, and we'll analyze them for consistency, for appropriateness. One example that we'll need to look at is what's the lowest cost and the highest cost of the subregions that are within a region, and what's an allowable differential between that highest cost and that lowest cost. Should we allow a 10% differential, a 20% differential? We'll have to see. Now, during this analysis, we have to be mindful of the marketplace, because we have to make sure that we don't bring back a scenario that the regional cost is out of line with what the public agencies can gain or can achieve in the marketplace. It's a quick way to lose membership that way. And then finally, we'll seek stakeholder input along the way. So to speak about that stakeholder input, I'm going to turn it back to Sherry.
Thank you, Gary. So the health team has been working with the Office of Stakeholder Relations. We want to make sure that everyone has a voice in this, that's impacted by regions, is going to have a voice in this dialogue. We are planning outreach efforts. We're going to be meeting with our employer association leaders, our labor representatives, and our retiree associations that are affiliated with the public agencies. We're also going to conduct a webinar to kind of educate everybody about regions and exactly what you've heard currently, and what they'll hear the same thing. And in late summer, we're going to start meeting with our stakeholder groups. In October at Ed Forum, we're going to have a focus group where we target specific groups that are the most impacted, and then we'll follow up again with the different groups I mentioned earlier to kind of regroup and talk to them about the findings we had in November and bring it back to you as well. We have additionally set up an email box, and we encourage everyone to provide their input and feedback there, and we sent out a survey on June 29th to all of our PEMCA contracted public agencies. And to date, we've received 180 responses. So we're looking forward to seeing what that looks like. And we're going to close that down on Friday. So if anyone who would like to participate has not, I would encourage you to do so at this time. So with that, I am going to talk about, we will be back to you in September to talk about what we've seen so far and the survey results. In November, we will come to you with some options on the table, and in December, we will probably look to you for some type of potential solution or opportunity, I guess is the right word. And I would welcome any questions you have of me or of the gentleman next to me.
Thank you. Are there any questions from the board?
Yes,
Oh, yes, Mr. Rubalcava, please.
thank you. This is very intriguing to me, and I understand from the introduction that there's two issues that are very important. One is the regional factors, and the other one is just the regions. And today we're talking about the regions. I have a lot of questions on the factors, and I guess I missed the January offsite, so I'm looking forward to the November. I have some questions on the regional factors. But in Mr. Cosway's presentation, he said one of the earlier analysis was looking at the healthcare market features of each county. Could you explain me what are some of those healthcare market features, for example, that might be different from county to county or region from region?
Well, fundamentally, the two drivers of healthcare cost in a county would be the utilization, sort of separating out, assuming you were dealing with a fixed population, how does the delivery system, how much utilization does the delivery system produce in a year? So what are the clinical practice patterns? How much managed care is there, capitation, et cetera? So one is utilization, and then the second driver would be the unit cost. So looking at contracts between insurance companies and providers, hospitals and physicians, what are the unit costs associated with those contracts? So those would be the fundamental drivers of differences in sort of underlying health costs from county to county. And those aren't necessarily easy to measure, but those are what we think we're going to see when we look at the observed per person cost. We think those are going to be the underlying factors that will drive the differences from county to county.
Thank you. And I had a question on the stakeholder engagement. Is there any outreach to the agencies that are not participating currently in CalPERS to find out what would attract them or entice them to come into the system?
Yeah, we've worked with the Office of Stakeholder Relations, and they've distributed our surveys and our responses to over 800 folks in their database. Of course, we always want to not just retain what we currently have, but attract more. So yes.
Thank you, Ms. Little. I have one more question. I'm not sure, I think this probably fits more on the discussion on the regional factors, but I'm sure it does. And this is about the pricing, so I should hold off on that, the pricing between the medical carriers and, yeah, I think I'll hold off on that. I think it's
You
a
wanna
pricing
hold off
thing.
till we have that
Yeah, I
conversation?
think that's a factor.
Okay, terrific,
But
thank
thank
you. Well, I know that if George Lynn were with us today, he would certainly give some public comment. I know he had a lot of views on regional factors, and I regret that he's not here for this journey that we're going to be taking over the next several months. But we do have two members of the public who've requested to speak, J.J. Jelincic and Donna Snodgrass. If you could each come to the microphone, identify yourself and your affiliation for the record, and you'll have 3 minutes.
Thank you, Donna Snodgrass, Retired Public Employees Association, and believe me, George is here in spirit. I may be premature in the request or question that I'm going to ask, but in the upcoming analysis, can we consider the possibility of retirees choosing a plan that in a different region from where they live now? We can't do that right now, but before we retired, we could use either our employer's address or our home address for the health plan. That goes away when we retire. So as an example, if a retiree could show that there's a Kaiser facility within 10 miles of their residence, but their residence is in a region that Kaiser doesn't exist, could we possibly put that into our, am I premature for this, I guess, but I want to ask for that, to give us some options, especially in the Greater Bay Area, where the PPO region is really super expensive. If someone lived on the edge of that region, even just this little minor adjustment to the regions and the availability to the other plans would probably go a long way to help some of our members. Thank you.
Okay, thank you, Ms. Snodgrass. Mr. Jelincic.
J.J. Jelincic, again speaking for me. The regions are really important. Costs do matter, and they do vary. As you do this analysis, it's really important that it be driven by hard numbers. We've got a database now that's got quite a bit of experience. One of the issues that came up was using risk adjustment in those. Everybody on the board is aware of the problems of risk adjustment. That's not to say it shouldn't be used, but it really does need to be thought about. I think there's something to be said for using the covered California regions, even if you use the older, 9 regions, simply to take more of the politics out of it. I will remind the board that when we made really a political decision to move Yolo into Sacramento County, we reduced the premiums for about 3,500 people and increased the premiums for 56,000 people. So it really does need to be number-driven. The issue of lost leaders, you're always going to have that. But there's a couple of values that I think need to be thought about, and that is requiring coverage of retirees. I think that's a core value of the system, and we need to leave it there, even though it does exclude some people. And high deductible health plans, put a spike in it. Thank you.
Thank you very much. Mr. Slayton.
Thank you. Sorry, I did have my microphone, but
Okay.
just 2 comments, 1 question and a comment just in regard to what Mr. Jelinek just said. Keep in mind that the 3,500 people in Yolo County who had a significant premium reduction was in fact offset by an increase in the Bay Area that was minuscule for the 56,000. So you have to look at it also in terms of scale. I did want to ask Mr. Causeway, because I'm a board member of a special district with 2,000 employees, and I know most special districts in California, and there are 2,000 of them, many of them are relatively small, but why would we leave that out of the analysis? And to me, that's an important component that needs to be included as we do this analysis.
We don't intend to leave it out of the bigger analysis. At this point, we wanted to see what percentage of employers were in CalPERS. And so we can count cities, we can count counties, count school districts. We had a hard time, and maybe you can help counting the various special agencies and other government entities within the state that have the option to take CalPERS, but there's quite a variety of those entities.
Yeah, well, I think the California Special District Association might be able to
Yeah,
help you do that.
but so we intend to do that, but we didn't know what we knew how many of those CalPERS has, but we didn't know
The rest.
the denominator for that. So, but we do intend to look at that.
Thank you.
There's obviously a lot of those in CalPERS.
Thank you. Any other questions or comments from the board before we draw this session to a close? Okay, well, I really want to thank you, Sherry, Gary, and Robert, for the detailed analysis of the healthcare regions. This concludes our morning sessions on healthcare, and now it's time to take our lunch break. But first, let's give our panel a round of applause. So on behalf of the board, I want to express appreciation for all the information that's been presented by all of the teams and our panelists this morning. And let's meet back here at 1:45. Enjoy your lunch break.